Hello, everyone. Welcome to Decoding Respiratory Medicine. I'm gonna welcome you again to one of my new presentation regarding IPC, that is Induling Pleural Catheter. My name is Sidra. I'm one of the respiratory physicians currently practicing in UK, and with the help of one of very good nursing staff who is taking care of the patients of IPC, Ileona, we will try to teach you something regarding IPC drains. Let's begin. So IPC basically stands for Induling Pleural Catheter. It's a catheter technique which usually we are using it for pleural drainage of malignancy or mesothelioma patients because it can drain for a longer period of time. Regarding the drain, it is a silicone tube tunneled and secured subcutaneously with a profibrotic cuff and ends with a one-way valve. It is used to remove an excess amount of fluid from the chest. As you can see in this picture, this is a silicone tube. It has a one-way valve, a profibrotic cuff, and a fenestrated length as well. So silicone catheter, the reason we are using the silicone catheter, it is more soft, flexible, conforms to the pleural space, and minimize insertion site discomfort. This profibrotic cuff is a polyester cuff. It promotes a tissue ingrowth to help reduces infection risk, and it also helps to place the catheter securely in place. These are the fenestrated fenestrations. These are large, smooth fenestrations with beveled edges. They promote drainage and help to avoid plugging. And this is the safety valve. So, for those who don't know what is a pleural space, it is outside lungs, not the inside lung. Uh, s- and this is the effusion, as you can see. Uh, we usually place this catheter inside, and this can drain excess amount of fluid. And this picture in the zoom telling us in more detail that this is the visceral pleura, this is the pleural space, and this is the parietal pleura. Sorry. Next, IPC are increasingly being used for patients with malignancy. More than 50% of all malignancies present with recurrent malignant pleural effusions. RMPE are defined as the pleural effusions that reoccur despite of an optimal therapy for the underlying etiology of the effusion, and it typically requires a multiple thoracocentesis or a more definitive therapeutic modality to prevent its reoccurrence. In this cases, the IPC work. IPC not only relieve dyspnea, but it also improves quality of life. It has a very good advantages of ambulatory effusion. Drainage can be done by patients or their carers after a minimal training. So this is a very important and good point, and it revolutionized the care of pleural effusion patients. IPCF emerged as a very effective modality to treat and control recurrent malignant pleural effusions. Once a patient develops recurrent malignant pleural effusion, only a mechanical drainage relieve a pulmonary compression and dyspnea. And for mechanical drainage, we need IPC. So now Ileona is going to tell you about some steps which can be taken and how we can insert this important thing.
Hello, everybody. Cedar, nice to see you today. And as Cedar said, I'm one of the nurses. I'm looking after IPC, and I will try to explain you shortly about the procedure. Procedure done within the half an hour time and in sterile environment. We using ultrasound to mark the spot for placement. 2 incisions 5 centimeter apart made for the tunneled entrance, subcut tunnel. One end then goes into the pleural space using the soft dilator. That's what Sidra is showing, that's the hard bit and sharp end for tube to be advanced or pushed through the incisions to stay in a tunnel space where the profibrotic cuff, which was mentioned previously, will be grown in to hold the tube in place subcutaneously in the body. The second picture that you can see already picture with tunnel catheter created. The third picture will show us how we're inserting the flexible part, fenestrated part into the pleural space, and the soft catheter will be removed after we advance the tube through this catheter. And the last picture will show us the end of the procedure, which is nice insertion with no complication. And 2 stitches will be placed. One will be subcut stitcher just to close the skin, and one will be stitcher holding the tube in place for a couple of days till the profibrotic cuff will be ingrown into the muscles. The dressing placed on a catheter, you can see how nicely it looks like. And if nobody knows what's going on with the patient, they won't see this dressing and they won't see anything. Patient can live normal life, can go shopping, can go on a cruise. And as Cedra said, we can teach the carers, we can teach the family members, and patient quality of life will improve. The only thing about the dressing I want to mention, to place the dressing not on a plain tube, but place the dressing on top of the gauze. Otherwise, the dressing can be used in a shower. It's shower-proof, but not a bath-proof. Patient can have a shower with this dressing. But if you will place this dressing directly onto the tube, it will be impossible to remove the dressing, and you need to cut it off the tube. Cedra, I will leave it to you now.
Thank you so much, Ileona. Now I'll continue with the complications. So complications related to the long-term presence of pleural catheter, they are usually managed conservatively, but some complications may require a catheter removal as well, and sometimes we might need to do a more aggressive surgical interventions. Some of the complications are like pleural infections, loculation, catheter tract metastases, blockage, severe chest pain, dislodgement, and external catheter fracture. We'll discuss each of them in detail. So, pleural infection, it accounts of 1 to 9.6 percentage, which is not a lot, but this is the UK data. And the treatment is antibiotic therapy. But if the patient is not improving, we might need to remove the source of infection, and we might need to remove IPC drain itself. Loculations 5 to 14%. There are certain trials going on in which we can place an intrapleural fibrinolytic therapy or intrapleural DNase therapy to remove these loculations. Catheter tract metastasis, there are certain studies as well that IPC could lead to catheter related metastases, but account for only 5%. For that, radiation therapy for isolated lesions might need to be performed. In less than 5% of the patient, it might block. So, flushing the catheter with a saline solution and teaching the patient as well is the solution. In certain cases, if it's completely blocked and not flushing at all, we might need to remove and replace an IPC drain. Certain patients might complain of a severe chest pain, that's 0.6%. So, for those, we have to prescribe analgesia, and in severe cases, the procedure not tolerated by the patients, we might have to remove a catheter. Dislodgement. Keeping anchoring suture at the entry site of the catheter for a longer duration, it's the solution, but in some patient it might dislodge as well. So we have to keep this thing in mind as well. Then there's one more thing which we usually forget. It's an external catheter fracture, and in that case we might need to replace a valve end. As you can see in this picture, infection of an IPC with a partial dislodgement. So there's an infection as well, and there's a partial dislodgement. Catheter-related infections, when a patient develops a signs of infection, as you can see, there is a purulent discharge, erythema and redness around the drainage site. We have to take a cultures which might be positive, or on examination there is some purulent, the pus coming out. We have to check for any specific organism. This diagnosis is quite straightforward, but the treatment might be some complicated because some of the patients might responding to antibiotic therapy, so we need to remove the catheter. As you can see in this, cellulitis of an IPC could be a pressure sore, grade 2. In that case, we have to take culture samples and start antibiotic treatment. If not resolving, might need to remove IPC. So chest pain is frequently encountered after IPC replacement. It occurs in 36% of patients, but usually mild and resolved within 3 days after insertion. So we have to counsel the patients that it might take 3 days for a pain to go off, but can easily be managed with analgesics. Negative pressure that develop during drainage of IPC may result in pain, can be managed by slowing or stopping the drainage. IPC blockage, uncommon complication, less than 5% of the cases, because we usually guide patient that flush the catheter with normal saline solution, but it could happen. Partial blockage, more common than complete blockage. Blockage of IPCs can result from accumulation of fibrous exudates inside or around the catheter lumen. Can be usually managed by flushing the catheter with saline solution using an aseptic technique. This is a very good picture showing a IPC dislodgement. It could be related to immunosuppression or cancer-associated cachexia that could delay a catheter adherence to the site of entry. This is a catheter tube external fracture. So for that you have a replacement, or you have to completely remove, cut the tube and then attach this to the tube, or in some cases you have to remove and replace it with a new tube. Now this is very important. How frequently should we do a drainage? So initial IPC drainage recommend that 3 times per week, with subsequent adjustment based upon volume and drainage associated symptoms. In palliative cases, we can do an alternative day as well, but usually recommended that not exceed more than 1000 ml per drainage. Normal drainage lasting around 20 minutes. Adjust drainage schedule according to the symptoms and volume. Dressings are usually invisible under clotting, so patients are usually like going for shopping, going for vacations, and doing every stuff they want to do. And the life is so comfortable with an IPC drainage. Family, family need to be good, and they should be encouraged to take a responsibility. If appropriate, with a name contact in cases of any difficulties. They can contact with the staff at the plural clinic or the doctors, and they can manage the complications later on. There are certain tips when draining. Strict hand hygiene is important whenever handling an IPC. Wound inspection for redness, regular inspection to look for redness, swelling, discharge, loose or broken stitches. Ensure that simple analgesia is prescribed and administered prior to drainage. Advise patient to control the flow rate by themselves by pushing and releasing the flow button. When the patient is comfortable with drainage, then allow to drain continuously with the slider. Drainage could be positional as well. Observe the vacuum indicator. When fully raised, drainage will ease. Thank you so much for listening to this video. I will still recommend to like, subscribe to my channel. And thank you, Ileona, for your help.
If there is any questions, you can write down and we will answer them as soon as.
Thank you.